My name is Liz Sharna. I'm the Executive Director of Pathways Serious Mental Illness Society. I'm coming to you here from the lands of the Musqueam, Squamish, and Tsleil-Waututh peoples with our office in North Vancouver. Pathways supports families who have a loved one with a serious mental illness. So we provide support in terms of peer support, one-on-one support, support groups, education. We have the license to present the NAMI Family to Family Education course, which has changed lots of people's lives and gives really good information about understanding serious mental illness, about treatment. We get to meet other people, other family members who have a loved one with a serious mental illness. We provide advocacy and have a really strong advocacy committee. We also have lots of information on our website through our staff, and we have a little library that we can lend you books. So you're welcome to any of that here at Pathways. So tonight, we are so pleased to have Dr. Mahesh Menon, who is a clinical associate professor and co-head of the Schizophrenia program in the Department of Psychiatry at the University of British Columbia. He's also a psychologist with Vancouver Coastal Health, where he leads the BC Cognitive Remediation Training Advanced Practice. Dr. Menon is the principal investigator of the Psychosocial Interventions for Functional Improvement Lab. His research program focuses on psychosocial interventions for severe mental illness and on the cognitive and neural basis of delusions and hallucinations in psychosis. He has published over 80 scientific pages and book chapters, and we're so very pleased to have him with us tonight to present. So welcome, Dr. Menon. We'll give you a chance to share your screen. And just to let you know, we will take questions at the end of the presentation. So if you do have questions, you can send them to Aurelia at, what is your name, Aurelia? Pathways?
Yeah, Pathways SMI Society.
Okay. So in the chat, if you want to have a question, send that to Pathways SMI. And yeah, so we'll have questions at the end of the presentation. So there we have
it. Okay, so I'm hoping that all of you are seeing my PowerPoint slide.
Yeah.
I'd gone back and forth between a couple of laptops and found that I may have had like the last but one version of the doc here. So I apologize. I have for many years run my lab with Todd Woodward, and our lab is called the Cognitive Neuroscience of Schizophrenia Lab. And more recently, we have two virtual labs. So mine, because I'm suitably nerdy, is called the Psychosocial Interventions for Functional Improvement, or Sci-Fi Lab. And Todd, who's become really interested in brain networks, their lab is, so Todd's lab is the Brain Dynamics Lab. So we still work very closely together, but I take the lead with some of the clinical studies. So what I thought today I might do is talk to you a little bit about some of the role of sort of psychosocial interventions in recovery from psychosis itself. And then we're going to also use this as an opportunity to tell you a little bit about some of the studies that our lab is running that we are in the process of recruiting participants for. So if you know someone who might be interested, this may be an opportunity. So I'd like to start off by acknowledging that I live on the traditional, ancestral, unceded territories of the Coast Salish peoples, and I thank you for acknowledging the different traditional homelands that you are joining from. And I also recognize that, I work within a health system which does a lot of good, but is also connected to a discriminatory and a number of colonial practices that have a lasting legacy and continue to create barriers for Indigenous peoples within the healthcare system. So what I wanted to talk about today, very briefly, just what is schizophrenia. We're going to talk about really the biopsychosocial model with a particular focus on the psychosocial components, just so that we can leave enough time for questions, highlighting what are some of the psychological interventions and kind of how we think these might play a key role in recovery and wellness. So schizophrenia is part of like a collection of diagnoses, the schizophrenia spectrum disorders, if we can call it that, which are characterized by a number of different symptoms, and some of those we think of as like kind of clusters of symptoms. So the positive symptoms are the delusions and hallucinations, as well as something that we sometimes refer to as thought form disorder, which is also kind of associated with some disorganization of thought and sometimes disorganization of behavior. Along with that, we have what we call the negative symptoms, which is a reduction in motivation, speech production, increased apathy, social isolation, and so on. And then there are also the cognitive symptoms, which are not necessarily diagnostic, but are a very, very common associated feature that I'm going to spend a little bit of time talking about. These are declines in memory and attention and executive functioning, as well as kind of the components of cognition which are involved with social interaction. So social cognition, as it's sometimes referred to. And the result of all of these, because they tend to have an onset typically in the mid to late teens for males and a little bit later, kind of late teens to the late 20s for women, tends to result in, a real profound disruption of everyday life functioning. So hallucinations can happen in any of our sensory modalities, and these are really aberrant perceptual experiences. And the most common types are the auditory hallucinations in psychosis. And these are characterized by most commonly people hearing voices, which could be voices commenting or sometimes threatening or critical voices, and sometimes what we call command hallucinations. And so these are quite disruptive to the person and really have kind of a profound impact on their quality of life. I just want to confirm the screen share is still happening. There's not an issue with that. Yeah. Okay, great. In addition, the other positive symptom are what we are delusions, which we can really think of as like the most kind of defining characteristic in some way of psychosis. So one of the early phenomenologists who had studied this was a person named Carl Jaspers, and he had said like this is sort of like the basic characteristic of like madness, as was referred to at that point quite pejoratively. But we think of this as these beliefs that someone may hold on to, which are not held by other people around them. And it is thus a false belief about what is happening in the world around them in external reality, which is held firmly despite perhaps evidence to the contrary. And lots of times these are extremely unlikely. The most common types of delusions that a person may experience are the feeling of paranoia, where the person feels like they're being watched or monitored, and they are coming up with an explanation for why they have such a strong feeling of that. And that explanation, the belief that they come to there, becomes what we would call the delusions of persecution. And that can be kind of a sense of like either someone trying to physically harm them or reputationally harm them, where they may be believing that people are talking about them behind their backs and so on. And a very closely associated experience that people often have are what are called delusions of reference, where people get the sense that they're getting messages from the world around them outside. So this could be a sense of feeling like what other people are saying is actually about them, or something that they see on the TV or the radio or on the paper is actually talking about them, or there are meanings in things like license plate numbers and so on. Sometimes people have what are referred to as delusions of grandeur. This is where someone might feel like they have special powers or abilities that they don't have. And then there are others which happen less commonly, where someone might feel like their body is being controlled by other people, or they may feel like they have thoughts that are put into their head or taken out of their heads, sometimes a feeling of jealousy, and a number of other experiences and unusual beliefs, like, very strong uh, religious delusions and so forth as well. So when we think about the illness, as with all sort of modern conceptualizations of both physical and psychiatric disorders, we tend to use kind of what we think of as a stress vulnerability model, or this we sometimes call the diathesis stress model, which suggests that we all have a genetic or biological vulnerability to developing certain illnesses, and environmental or external stressors can increase the risk. These could be physiological or psychosocial stressors, which could be, due to bullying, trauma, drugs, head injuries, and so on. So the idea with the biopsychosocial model is that there are deficits which can arise at different levels. There is no one gene which is necessarily leading to the development of psychosis or depression or any other condition like that, but rather those genetic vulnerabilities might, for some people, lead to varying levels of kind of neurodevelopmental, again, vulnerabilities, which could in turn lead to sort of changes in neuroanatomy, neurochemistry, which could in turn lead to changes in kind of brain networks and how the parts of the brain are connecting and communicating with each other, which could then lead to problems with cognition or social functioning. And they may also be more responsive or sensitive to the effects of physical, physiological, or psychosocial stressors. And these are all sort of small effects individually, but there may be kind of combinations or incremental processes which are happening. And we don't really kind of understand all the pathways, but we know that there are some things which are increasing the risk towards that. And so in the range of sort of psychological or social stresses, for instance, we know that trauma can increase the risk of developing psychosis. Even kind of small t trauma like bullying that someone might experience in childhood, in schools, and so on, can increase the risk of developing it. Anxiety and things like, say, substance use, which can have a direct or indirect effect, can all kind of have an additive and cumulative effect. So really, like, we are trying to understand the illness, this illness and others, like most of our work is centered around schizophrenia, looking at it at these different levels of understanding, if you will, right? This is our research model of it. So, we can understand at the level of genetics, at the level of kind of low level kind of processes that are happening physiologically in the brain, in terms of neurotransmitters and neuroreceptors, but also kind of going further downstream from there, that could in turn lead to, dysfunctional neural networks, which could lead to kind of some of the cognitive factors that we see, which could in turn lead to the components of the illness itself. Now, we can kind of see schizophrenia in two ways. We can kind of think about what are the characteristics that are associated with someone who might develop this. So we sometimes refer to these as trait characteristics. So someone who may be vulnerable to developing psychosis, for instance, may have, for instance, problems with verbal memory or problems with executive functioning. And this is a relatively stable aspect of the illness. It's not kind of fluctuant or based on the other symptoms that they're experiencing. And separate from that, we can also think about the components of the illness which are changing over time. And we think about these as the state aspects of the illness. So thinking about state and trait aspects is one way that we may think about, like, addressing different types of challenges, impairments, et cetera, which are arising. And, the different interventions that we have kind of come at this model at different points, right? So we know that medications play a very important role in recovery from psychosis. And we know that that's acting at the level of the neurotransmitters and the neuroreceptors. And then further up, when we think about like what is happening in terms of like daily life cognition, our thinking patterns, cognitive biases, as well as other aspects of the memory, attention, and those basic cognitive processes, those are the psychosocial interventions like cognitive remediation and psychotherapy. That is kind of the level at which those are going to have an impact. So hopefully that just sort of like sets the background for like how we're thinking about the illness and what are sort of the places where we might want to intervene. And then in terms of like what is happening in the level of the brain and the brain networks themselves, this might be places where other interventions like neurostimulation could play a role. So, you know, things like TMS, TDCS, and so on kind of can come in here. So I want to talk about two classes of interventions broadly. So cognitive remediation is an intervention which is really focused on improving basic cognition. And then there are a number of psychotherapeutic interventions, including CBT, MCT, and so on that I'll talk about, which are really kind of getting at different symptoms themselves. So cognitive remediation aims at improving basic cognition in schizophrenia spectrum disorders, as well as other mental health conditions. And it's helpful for us to think about like, why is it important to address these cognitive deficits? Now, while it's not been commonly talked about, because it's not specific to schizophrenia, so we can't use it as a basis for the diagnosis, but we know that problems with cognition are actually a very reliable finding in schizophrenia spectrum disorders and maybe a core feature of the illness. That's not to say everyone who has psychosis has it. You know, there are people like John Nash who won the Nobel Prize. There's so many brilliant people who have it, but many people say that there are aspects of their cognition which were impacted when they developed psychosis. And we know that the magnitude of these cognitive deficits does not correlate with the severity of the positive symptoms that a person is experiencing. So how much we may struggle with our memory is not necessarily correlated to how bad the voices are, for instance. But rather, we do know that the magnitude of those cognitive deficits is actually quite a strong predictor of how someone may do in daily life, in employment, independent living, as well as quality of life. So we can think about what we call the 5 Ps. So challenges with aspects of cognition are pervasive. Many people, most people, I might say, with schizophrenia spectrum disorders have some level of cognitive concern. They tend to be persistent over the course of the illness. So they present early. We think there's a bit of a 2-hit model. So oftentimes prior to the development of the first episode of psychosis, young people will talk about having difficulties with attention, concentration. Family members say they notice how their school performance dropped in the year or so before the symptoms developed. And it may be associated with other symptoms they may have been experiencing at the time, depression, anxiety, and so on. But we know that they present early and they progress early and they predict functional disability. So when we look at how the sort of cognitive patterns unfold, this is from an old study, but this has been kind of very well validated in a number of other studies that have happened since. So that dashed line on the top that you can see, the 0 line, is the sort of like average score for people of the same age who don't have any psychiatric diagnosis. And the open squares that you could see there is a group of young people with a first episode of psychosis, so within about the first 3 years of the onset of symptoms. And the filled blocks are a sample of people who are more than 5 years into the illness itself. Now, what I want you to notice is that the pattern of deficits, so these are basically scores, which is like the average of these across different domains like attention, abstraction, verbal memory, processing speed, visual memory, and so forth. And what you'll notice is that all of this, the patterns of those scores look kind of similar. People who are more than 5 years into the illness show a little bit more of a drop. but for the most part, we can see it's the same pattern. And these Z scores that we're seeing that's a sort of a statistical kind of calculation. This sort of is between, for the most part, between 1 and 3 standard deviations below the mean for non-psychiatric control participants. What that means is that in terms of a percentile score, that is anywhere between sort of the 20th down to like the first percentile. So about 80% of people or to 99% of people are actually doing better than some of the folks with psychosis that we're seeing there, which is quite a huge drop. And so it does make it quite important, because when we look at the impact of these on daily life functioning, this is again kind of some fancy statistical modeling that's done by our colleague Chris Bowie, which looks at the relative impact of positive and negative symptoms and the effect of those domains of basic cognition, attention, memory, executive functioning, and processing speed. And we can see that these have an independent effect on community functioning and work skills and so on, separate from the effects of positive and negative symptoms itself. So this is showing that these are very, very important to daily life. And it's not like those deficits kind of continue, but there is kind of a two-hit that's happening. Kind of prior to the onset of psychosis, there seems to be some cognitive challenges that occur. And then subsequent to that, there is kind of a second hit. And when we look at kind of what's happening in the brain, this is some data from a study that was done in our lab a few years ago using a working memory task. So people will do, see 2, 4, 6, or 8 letters, and then they have to hold that in mind, and then they're asked, oh, is this one of the letters that you saw? Now, again, the brain networks don't really matter, but when we look at activity in the brain network, what we see is in the controls, the graph on the left, as the task gets harder, their brain becomes more and more active in those networks. But for someone struggling with psychosis, that activity is more in some of the easier versions. And once you've hit your peak activity, we can't go anymore. And that's where we start to see performance challenges that are occurring. So there's no part of the brain which is damaged. We think this may have to do with inefficient communication between different parts of the brain networks. And at higher levels of activation, where if we can't continue to kind of like, engage your brain more than that, then we kind of reach your performance limits. And so impairment at those high cognitive loads can, of course, impact everyday functioning. And so, some of the things where people use that really harsh term, like, is this treatment resistant? Someone who isn't engaging with their team or doesn't kind of have realistic goals or something, we can actually sometimes see this as like the consequence of cognitive challenges themselves. And so I think hopefully seeing it through this lens allows us to have more compassion and understanding for people who may be struggling and having some behavioral problems as well on a day-to-day basis. And this slide is particularly, I think, relevant for care providers, much more so than family. But I actually wanted to point out how we are trying to share this message with kind of care teams as well. So in order to improve these domains of basic cognition, we use an intervention that's called cognitive remediation. And this is an intervention targeting cognitive challenges using the scientific principles of learning with the ultimate goal of improving daily life functioning. And the components of this kind of involve one aspect is really like recognizing that this isn't just, like a computer exercise that you do. So if you just did those computer exercises, you get better at the computer exercises. But when we do this in a structured therapeutic group where the therapists and participants are working on understanding what are the cognitive challenges that they're dealing with, how is that kind of getting in the way of the goals, doing the computer exercises is a way of increasing neuroplasticity or kind of network efficiency. But alongside that, helping people to become more aware of how can I work smart on this, develop more effective problem-solving strategies, and then generalize that from the computer activity into real-world tasks. So that is kind of the components of an effective cognitive remediation intervention. So we are doing a large pilot project across the province with support from the Ministry of Health, who've been wonderful and have really kind of supported the rollout of this, using an approach to cognitive remediation that we call action-based cognitive remediation, or ABCR, which was developed by our colleague Chris Bowie, who is a professor in the psychology department at Queen's. And this uses some computerized software from a company called Happy Neuron, which has exercises targeting lots of different cognitive domains, including memory, different aspects of memory, attention, and so on. And the action-based part is that in addition to what is happening with the computer activity, we have versions of real-life transfer tasks that they do. And then as a homework in between, they're practicing the computer exercises as well as using strategies in daily life tasks. ABCR kind of has its 16 sessions with 4 modules, which are attention, memory, executive functioning, and social cognition. And the sessions typically last around 2 hours. And I'll show you an example of the computer task. So this is an example of a task that's called the Towers of Hanoi or the Towers of London, where the goal is you want to kind of move those rings around to match that picture on the top right. And you need to do it in as few moves as possible, and you can't put a bigger ring on top of the smaller ring. So I can't, for instance, put the blue ring on top of the purple ring. So you could do this by brute force, or you can also start to use strategies to kind of do this, kind of smartly. So you might say, I'm going to take a big problem, break it into a series of smaller problems, and then address that, right? So the first problem is, how do I get the blue ring over to the right-hand side? The second problem is, how do I get the yellow one on top of that, and so forth. And that idea of taking a big problem and breaking it into smaller problems and addressing those one at a time, of course, is very, very helpful for daily life as well. An example of a transfer task that we might do in group is we have a little pantry that's set up, and you're told, okay, you've invited 3 people for dinner. You had planned to make lasagna and spinach and brownies, and you bought the ingredients, but then one of your friends said, can I bring 2 more people? One of those people is allergic to dairy, so you need to kind of go through, find what has dairy, problem solve, come up with a new recipe. Here are your recipe cards, here's your pantry, and then kind of people actually go through, look at ingredients, practice, using different problem solving skills, and we're linking those to the game that they've done as well as to the goals that they wanted to work on there. So it's been shown to be quite effective. We've had a really positive response to it from the pilot project that we've been running as well. I'm really enthused about that. Now, this, as kind of from our model, as I was saying, this really kind of gets at some aspects of like basic cognition, but it doesn't. It has a slight effect on improving symptoms, but really there are a number of interventions which really target the symptoms of psychosis. So these psychotherapies, kind of get at questions like, how do we kind of change the kinds of beliefs that we have? And, we know that medications helps with something, but lots of times we also know that when someone has a relapse in their symptoms, they oftentimes go back to the same beliefs, right? And so helping people to understand how can we kind of see why people have certain types of beliefs, what are the kinds of biases that lead to those beliefs, may help them in turn recognize like, oh, hey, I'm doing that thing. And that insight can then prevent these beliefs from really kind of, becoming problematic in their day-to-day lives. So we've been, not just our group, but a number of others had been doing a lot of work around like, what are the aspects associated with belief formation and delusions itself? Questions like, how do people arrive at different decisions and develop different beliefs, and why don't we change our mind in the face of like new evidence? So my PhD and a lot of the work that Todd had been doing way back in the late 90s and early 2000s was looking at things around, this question of like, how do we arrive at decisions? And we would use like this, versions of what we call a probabilistic reasoning task, which was a way of like looking at how much information people use to arrive at a decision. So in this task, people would have jars of beads, and then we would kind of hide them behind and take them beads out one at a time and say, tell me when you know which jar I'm pulling it out of. And we found that people who were prone to delusions actually tended to use less information to arrive at a judgment, and they would oftentimes be more confident in that judgment. And we call this a jumping to conclusions bias, and this is an unusual context. It has nothing to do with a strong belief, but we think of this as a risk factor for developing delusions. And on the other hand, when we look at like, why don't people change their minds? We know that all of us are actually poor at integrating what we call disconfirmatory evidence. And we had developed another task. This is Todd and Stephen Morris's work, where, for instance, we tell people, okay, I'm going to show you a story and I'm going to play this out backwards. And I want you to tell me what you think is happening in this situation. So when you look at this picture, what do you think is going on here? And how likely do you think each of these explanations is? So in this one, it's like a man just built a fence for his dog, or he's shopping for a guard dog, or he's escaped from a dog, or he's playing with his neighbor's dog. We think, oh, that looks like it's funny. Looks like he might be playing with his neighbor's dog, or maybe he's just built a fence. And then we see what happened just before that. That does look like he could be playing, but maybe he just escaped from the barking dog. And then that's what happened just before that. Now, in some of these stories, there's something which looks true at first, and then it becomes clear that that wasn't the case. So these are kind of the lures, and it allows us to look at how do we increase our confidence with information that fits with our prior belief, and how much do we decrease our confidence when we get information that doesn't fit with our beliefs. So again, we can do sort of some fancy stats around it to kind of understand how we integrate disconfirmatory evidence. And what we find is that if someone has really quite strong paranoia or these strong delusions, they are less able to effectively integrate disconfirmatory evidence in there. So we call that a bias against disconfirmatory evidence. And we think that that could be a maintenance factor for maintaining the strength of the belief, because as they get information that doesn't fit with that belief, they're not able to effectively integrate that and update their beliefs accordingly. And there's a lot of other research on other cognitive biases that comes up, and some of the psychosocial interventions that have been developed really kind of help to target these thinking biases, cognitive challenges, as well as kind of other things like the impacts of trauma. There have been many, many psychosocial interventions which have been developed for psychosis. I talked briefly about cognitive remediation. The most well-validated ones are cognitive behavior therapy, metacognitive training, and those are two that we have been using extensively, as well as kind of now newer treatments like avatar therapy. So I'm going to really skim over the CBT aspect of it. It's the most well-validated intervention, but the idea is it is really helping people understand that our emotions can bias the way that we see the world, and then we often act as if those thoughts are true. And so, when we are struggling with an emotion like paranoia, that can bias the way that we see the world. That might make us have thoughts which are congruent with that. And then when we act as if they're true, it oftentimes inadvertently reinforces those beliefs. So, for instance, if I saw a friend walking across the street and I waved, she didn't wave back, how I make sense of that situation drives the emotion, but the emotion that I'm having also makes me more prone to having certain types of negative automatic thoughts, right? So finding ways to actually sort of target those automatic thoughts can be quite helpful. And, so we might kind of challenge the maladaptive thinking or the sort of cognitions or the behaviors, things like safety behaviors, checking, distraction, escape, and so on, to stay in situations and recognize that we're safe. So these are parts of the sort of treatment for CBT, and it's really important to recognize, that our goal for the most part is reducing the distress caused by the symptoms, prevent relapse, improve mood and self-esteem, and really kind of engage the client as an active participant in treatment. So this is the most well-validated of the psychological interventions in terms of the number of studies that have been done, and is considered like one of the gold standard interventions. The other one that has been very widely used and that was developed by our colleagues is called metacognitive training, and it was developed as a knowledge translation tool and then built into a clinical intervention based on that. So it can be done as a group or as an individual treatment. And it really focuses on the cognitive biases that we talked about earlier, particularly the jumping to conclusions and the bias against disconfirmatory evidence. It's widely available. It's been validated for different languages as well. And it's 10 modules. Each training module really kind of looks at one of the biases or different aspects of it. And what we are trying to do here with our groups is really make it quite experiential. So rather than sort of telling people about it, we also sort of help someone say, like, here's how it might play out in day-to-day life, but we're doing it in a fun, playful way, and we're really normalizing it because we're all vulnerable to and prone to having those biases, right? So, and this is an example of an exercise from the MCT module. This is from the second module. And basically you're told, you're going to see parts of a picture. And I want you to tell me when you think you know what this is a picture of. And we're going to run through this here for reasons of time. But, um, in the group, we have a lot of discussion, play around with it, have fun with it. What could this be? This could be a face, a bowl, a sled, an elephant tusk. And, we say, like, if you were to like bet on that, like, would you say I'm 100% sure, a little bit sure? And people have guesses, and then we say, okay, what could that be? Oh, you know what? That could be the tusks. That could be a rocking chair. That could be a sled. And then at some point we start to become more sure. Oh, wait, no, I'm pretty sure that's a rocking chair now, not a sled or anything else. So we're really helping people recognize that, there is that balance to be found between making a quick decision versus making being very sure. And sometimes, we need to make a quick decision. Sometimes we need to slow down because, if we don't, we may get it wrong. And at other times, we may not see the full picture. You see this, what do you see? You might see the old couple, you might see a goblet, and we can take our time, zoom in a little bit closer, and now we see like it's kind of one of those like fun paintings. And the idea here is to allow people to recognize, sometimes it's not we're getting it wrong, but that we're not seeing the whole picture. And this allows for just like a lot of good discussion. We slowly try to connect that back to people's own life experiences. And then we say, look, your homework in the week is to basically try to look at what is happening in between. Are you noticing if you're kind of falling prey to some of those biases or thinking traps? And how do we, by noticing it, find a way around that? So those are two of the interventions which have been kind of particularly used around beliefs and delusions. We are also now validating a new approach towards voices, which is called avatar therapy. And this is a kind of an interesting idea that came from some work around relational therapies, which the idea was that we are creating an avatar. So this is most helpful for people who have one dominant voice that they are struggling with, and the voice might be critical or threatening. And we create an avatar that looks like they imagine the voice to be, that sounds like they imagine the voice. And after that, the therapist basically verbatim says what the voice has been saying to them, and they practice responding back to the voice. And so this can be done on a computer screen or in VR, and start to have dialogue. So they practice assertiveness and self-compassion outside of those conversations, and then practice using those skills in dialogue with the voice itself. And the studies that have been done, there have been two big trials that have come out of the UK, and then one big trial that just came out of Denmark recently that found that people really had a greater sense of control and power. They felt really empowered in kind of talking back to the voices. And for a subgroup of people, really the voice intensity decreased and disappeared as well. So we're really hopeful that we may see some of like people having a greater sense of power in coping with the voices, as well as a greater sense of freedom to be able to do the things that they want to in their lives, despite what the voices might be saying. So we are just kind of starting off on this trial. So our hope is really that, this isn't an either-or situation. Medication will continue to play a really important role in recovery. And in addition to that, interventions like CRT may help to improve brain network connectivities. CBT, avatar therapy, MCT will help with kind of some of the symptoms and the thinking patterns that people might kind of be falling prey to. So that, our hope is by integrating these different approaches, we can help with really kind of meaningful recovery, right? And to have the lives that ultimately that we want for ourselves, and hopefully with preventing relapse as well. So I'm just going to skim through this. What are the studies that we have running right now? We have 3 different studies, which may be of interest to different people. One of the studies that we are running is an fMRI study where we're looking at memory itself, and we're looking at the relationship between what is happening in some particular parts of the brain, like the hippocampus, and some aspects of memory functioning. So kind of memory that we call associative memory. And so people who would be interested in doing this study would actually come in, do some assessments, do some questionnaires, and then do an MRI scan. So it's fMRI, and then they get a picture of their brain and what it looks like. And this is done over 2 sessions. For people who might be struggling with persistent voices, we are just doing a small pilot trial that we're just getting started on now, which is a study of avatar therapy that I described. And then the third trial that we're doing is actually asking a slightly different questions. It is saying we know that CBT by itself has been helpful for improving symptoms, and we know that CRT by itself has been helpful for improving basic cognition, and they are 2 routes towards improving functioning. And we're looking at whether combining the treatments enhances outcomes beyond each individual one. So this would be a randomized controlled trial where people would get assigned to one of 3 different arms, CBT or CRT, or the combination of the 2. So if you have someone who might be interested in it, for the fMRI study, our email address is braindynamics@ubc.ca. And for the other one, it is my lab email address, which is sci-fi.lab@ubc.ca. And the psi is spelled like PSI, which is the Greek letter for psychology as well. So just a super nerdy email address, but bear with us for that. Or you can call us at our lab phone number. We'll share the information with Liz. She can share it out with you as well. So that's it. And hopefully I can stop the share as well.
That's great. Thank you so much.
Oh, yeah.
Yeah, very interesting work that you're doing.
I'm not quite sure how to stop the share, or maybe it's okay. Has the screen sharing stopped?
No, but it's
Okay.
nice. That's great. Well, we did have some questions come in ahead of time, so maybe I can ask you these questions while we're,
Sure.
and yeah, I'm sure we can get that off and get back.
There we go.
Excellent. Okay. So thank you very much. So some of the questions we have are there newer medications or treatment approaches that might have fewer side effects than traditional antipsychotics?
Yes, that is the hope. I will say, this is not this is an area that I'm familiar with just because I've worked for many, many years at the BC Psychosis program, but it is not the area that I do research in. I am a psychologist by training. We know that there are some new medications coming out. The one which has the most excitement around it is one called CAR-XT, which is a combination of 2 different medications, which we hope might have kind of fewer side effects. I think for a lot of people as well, there are kind of questions around looking at things like kind of lower doses over long periods of time, as well as kind of the potential stabilizing effect of long-acting injectables, or combining medications with interventions like neurostimulation, like RTMS, or what's called TDCS, transcranial direct current stimulation, or TACS. And so our hope is that there may be kind of combinations or treatment approaches which might be helpful to that, but again, that is a little bit separate from the work that we do.
Okay, thank you for that. And we were talking about it before, but so you have 3 clinical trials and you are still accepting people in all 3? So the September newsletter, if you want access before that, you can email me. Yeah. Okay, a few more questions that came in beforehand. Are there interventions that help with insight or treatment resistance?
Yeah, so again, our hope is for a lot of people who are struggling with aspects of psychosis, like kind of voices and paranoia, they might struggle to recognize that this is, a symptom of an illness. And we know that one aspect of what is associated with that is what we call anosognosia. And this is also like one of the core features of the illness. So that means it is a lack of awareness that I have the illness. And it is a condition which is sometimes, seen in like neurological conditions and so forth. But also, we can think about illness insight as a sort of actually quite a nuanced, multifaceted construct. There are some people who might have a complete, absolute sense of like, no, I don't think I have any illness at all. I think this is all, coming from somewhere external, like this is the CIA trying to harm me. Other times people have a fluctuant insight, or they may have a partial insight. They might say, I do have psychosis, but they may also think like, but I think the voices that I'm hearing are coming from somewhere outside. And they're trying to hold both these beliefs side by side. And so we know that, the biological medications do sometimes, as the intensity of the symptoms subside, people might find it easier to consider other explanations, right? And that does kind of help with the insight aspect as well. We also know that a role of these psychological interventions is to actually help people to develop an alternative belief. Because again, when we think about our own beliefs, if you've ever had an argument about politics or religion or your favorite sports team with a friend, a family member, a huge argument around the Christmas table, you know that none of us want to change our beliefs. It's very, very hard to change our beliefs. And so we know that that's not just like too related to insight, but also because it's such a difficult process. So in some way, the role of psychosocial interventions or the role of therapies is to help to allow us to develop an alternative model of the illness that may allow us to kind of shift our beliefs, right? So if we're able to say, this is one belief, but it could also be because I'm falling into these thinking traps. I'm jumping to conclusions a little bit easily. Or, there was a time in my life where maybe I felt unsafe, but I'm kind of carrying that fear forward now. And I need to recognize that I may be safe in the present. So that allows us to shift our beliefs a little bit more easily, which then allows for the development of then evaluating that old one as maybe inaccurate, which is a route to develop insight as well.
Right. Thanks for that. Next question, how do you support someone with schizophrenia to live as independently as possible, even if symptoms persist?
I think this is the $64,000 question that we all think about, right? And I don't think that there is one answer to it. I think it's obviously going to involve a number of components. I think all of you as family members end up doing the biggest, hardest task there, which is supporting them on an emotional and kind of social connection basis, right? And I think that as someone is trying to live independently, one aspect will be improving kind of daily life functioning. So getting at some of what we've been talking about with like cognitive remediation to help people, learn how to kind of do some of the tasks that they're working on. And I think, we have people within the mental health teams like occupational therapists and rec therapists who are already involved with that aspect. But the other thing would be helping people find places that they feel safe and can feel connected to other people. I think that level of social connectedness and having something outside of the house that we can go to can be really helpful in terms of continuing to use the cognitive skills, developing our social abilities, overcoming the isolation, helping with negative symptoms and depression. And I think that is the sort of other aspect of it. And, we know that there are some programs like Thrive, which have been quite helpful, but I think certainly finding connection and community, I think is the harder, but really important aspect of fostering independence as well. And again, I realize these are all things which are so much easier said than done, but I think those are the components that we would like to have. I don't have an easy explanation for how one goes about kind of developing that for each of us.
Yeah, no, I think what you said about being in community is so important, whether you're the person with the mental illness or you're the caregiver, the family
Absolutely.
member, finding community and connection. Yeah, that's really important. Okay, another question. How can we respond when our loved one refuses treatment or denies they're ill?
Yeah, so I think that this also, is one of the questions that always comes up when we are connecting with family members. And I think there's some wonderful work which has been done by other folks. Like there's a psychologist named Javier Amador, and he has uh, a, a tool. There's a book that he's written, and it's called the LEAP method. And there is the LEAP Institute, which has some resources on how can we talk to loved ones who are having a different perspective on what's going on for them. But I think that the gist of it really kind of boils down to how can we kind of stay in communication with them? How might we find, common goals that we want to work towards? So, me as a therapist, when I'm working with someone, I'm often thinking about like, my goal isn't to convince you that your belief is wrong any more than, anyone's going to have much success with me trying to convince me that my belief is wrong. But if I am distressed about something, I might be more open to talking about that distress. So I envision that when I'm working with a client who may be really anxious about going outside, we might say, okay, maybe our goal is how can we help you to feel safer getting out of the house, right? How can I help you get to volunteering or, make some friends or kind of like take steps towards getting a boyfriend or a girlfriend. I think those are like the common things that we all want for ourselves, and maybe those are the goals that we can agree to. So finding ways to continue to have those conversations around that can be sometimes helpful. And I do think that separating out our roles a little bit can also be helpful. And this might seem contradictory, but I think in some ways, as a family member, our role is to kind of be there for our loved one, and the mental health teams, the clinicians that you're working with, will hopefully be able to be the ones having some of those hard discussions with them. Because at the end of the day, you don't need to be the bad guy. I can be the bad guy in those discussions. And it's okay if, your son or daughter or loved one is mad at me a lot more than it's okay if they're mad at you, because you have to see them and care for them, and kind of, be able to provide the emotional support in a way that I, as a clinician, won't be able to do outside of the time that I meet with them. So I think, also picking our battles and thinking about what are the bits that we want to do, and allowing the team to be the people driving some of those decisions, to say, look, I'm just following what the team's asking me to do, can also be quite helpful.
I think I've heard that from lots of our families, and that's really great. To hear that from you about certainly knowing that you're part of that team. Yeah. And this question actually leads into that too. So this person's asking, are there psychiatric teams or clinics specifically trained to work with patients who are treatment resistant or have low insight into their illness?
Absolutely. I think that, the way a lot of our programs are set up, I mean, from early psychosis through to some of the mental health teams, through to very specialized programs like the BC Psychosis program, we recognize that this is really one of the challenging aspects of someone who may be struggling with psychosis, and it's something that we all, see as very much as part of our routine clinical care and responsibilities. So that's not to say that I always do it well or that my colleagues always do it well, but we certainly have a lot of training around it. So
No, that's great. And I mean, we're all human too, but I think knowing that, yeah, we have clinicians like yourself who are knowing that that's an important role. Yeah.
yeah, and I think, part of my, again, role kind of in advocacy with family members, as well as kind of as a clinician researcher working around these areas, is, I do a lot of training with medical students, psychiatry residents, psychology residents, mental health teams, to really kind of help them understand, the role of cognitive concerns, the role of cognitive biases, the role of like kind of insight, kind of how that might play out. And so kind of keeping with that continuing education aspect of it as well, both within our department and within the health authorities. So that's certainly something that I'm passionate about. And, it's always good for our clinicians to have reminders around some of these issues as well, and keep up on new research that's coming out as well.
Excellent. Thank you so much. Those are the questions that I had written that people had written in. Are there any other questions for Dr. Menon?
With someone from the RCMP or the police, can document that, and I think kind of having the documentation and kind of the ongoing confirmation of some of the symptoms, both with kind of collateral from yourselves and the GP, can all be helpful. I know that sometimes families do kind of want to ask for a second opinion, but I don't really want to wade into that. But sometimes I think that can also be an option. I do realize like that the catchments are a hard thing to deal with, and I think lots of times a good rapport with our clinicians is one of the most helpful things in the recovery process as well. So the other aspect that I might suggest is perhaps if your son's able to kind of get connected to some of the other programming that is able to support him, then I think having multiple clinicians be able to, there are like the cognitive remediation program that Susan had mentioned in the chat is being offered across the province, and it is offered as a virtual group, so he can access it from Langley on the computer with clinicians. We also have the MCT group, which is running within the communities as well, that we would like to offer, across the province, and can be done virtually also. So we'd like, and I know that Fraser has a plan to add that to the programming along with the CR group as well. So those may be at least different ways to like
sharing that, Carmen, and thanks, Dr. Menon. Yeah, I have a couple of more questions in the chat, and then we'll get to you, Joyce. Okay, so one of the questions was, what kind of treatment do you recommend with the treatment-resistant senior with olfactory hallucination?
Again, I don't want to weigh in on like specific treatments. I think what is important to do is certainly to sort of talk to their clinician, because I think it's important, especially as people are aging, to look at physical, metabolic processes, request the clinician to see if there are kind of other causes or things that could be driving it, as well as kind of ruling out other possibilities around kind of neurological conditions, olfactory tumors, that kind of thing. So just I think really kind of meeting with the psychiatrist, seeing if it warrants a referral to a neurologist, getting an EEG. These are all going to be important aspects.
Mm-hmm. Okay, and another question, how are you addressing the loved ones who cope with their illness through addiction?
Again, I think that is such a difficult challenge unto itself. And I think, the long answer of it is, different people have different reasons that can kind of lead them to feeling in that space. I think sometimes it's an escape from the intensity of the psychosis symptoms. And other times it can also be, coping with other difficult emotion states, whether that's depression or anxiety. At other times, it's a way of coping with sort of increased social isolation. And lots of these are like vicious cycles that we can be stuck in. So I think hopefully finding some support through the clinicians, through community supports as well, to get at developing, I think, not just like coping strategies and tools, but also some of what we were talking about earlier, kind of a sense of community or a reason to have something else to do. I think are going to be all really, I think, important aspects of the recovery process. Again, I think that's a very glib answer to a very tricky situation.
Yeah. Okay.
Roles, right? And I find that sometimes it's easier having those discussions about kind of new therapies with a clinician. Having said that, I think the time where someone feels ready for therapy really dictates kind of how much they're able to engage in it. In my own clinical work, unfortunately, I've had many loved ones who have said to me, look, hey, will you meet my son or daughter? And the hope is somehow that in meeting with me, they will change their mind and be willing to engage in therapy. And I wish I had that power, but I don't. And I will admit that most of the time I've not been able to kind of convince people to come into therapy. So I think that people kind of like oftentimes hear about it, they sit with an idea, it kind of percolates, and then maybe there's a time in their life where it feels right for them. And I think that is probably the best time for them to actually engage with us, because if they are forced into therapy or doing a group that they don't really want to do, it actually feels aversive to them. And then they don't actually go to doing it at a time where they might benefit from it as well. So that's a very long-winded way of saying, I would suggest if you think your daughter's interested in like what are some of the groups that are being offered, to say like, hey, do you want to kind of go check it out? Or you can kind of have them talk to their clinician who might be able to kind of present that information. Or if they want to kind of talk to us about it, we're happy to talk to them, whichever you think would allow us to kind of talk about it most frankly. But also give her the space to say like, you can come back to it at a time where you feel ready for it as well. And in the many years of working in this field, I know that some people will come to it at some point and some people might not, and that's okay. That this program, which was a pilot project, will actually be continuing forward, and we're looking at kind of ways that we can expand it out. And my hope is that this will be kind of part of the core programming, certainly within the Vancouver community mental health teams, and we hope kind of through all of the health authorities as well. But I think the best, I think, Susan, I will defer to you on like ways to advocacy, because I think you are certainly part of the impetus to sort of getting this funding for us initially. But certainly, I think like kind of communicating with the care teams to ask about those, so that I think we now have pockets of it where it's accessible. And a part of what I've been doing is trying to make sure that we can kind of reduce the barriers to access, so that people can access it, even if it's in a different community, through virtual groups, or to be able to kind of go in person. And I think around the questions around like increasing the advocacy to sort of expand out the program and kind of increase funding, I think is always where it goes to the realm of political advocacy, which I think is important. But I would do it. And hopefully I think them knowing where to kind of ask for it or find it as well can hopefully lead to increased access across the different kind of communities of care.
And to keep showing up and advocating for what works, right?
Yeah. Much harder to mandate. I think the strengths within that, which are easier to do, is you can have someone kind of take a pill. I think that, or get an LAI. I think that is a lot easier to manage than kind of engage in therapy. I think the important role within the involuntary hospitalization and the process, alongside the medication optimization and treatment, because I think that is a necessary step to allow us to kind of build on the other pieces. Exactly what you pointed out, is I think like we need to do that. We often will work on other aspects, like kind of like developing basically a humane relationship with the person, working on things like motivational interviewing, to allow us to kind of engage in other discussions. Being in a place where, if you're hospitalized under the Mental Health Act and actually you are able to kind of detox off the substance that you might be on, itself can, I think, be a game changer for many people who have struggled with those difficulties for a while. And it allows us to have a lot more discussion. So, I mean, in our therapeutic practices, that there is a very, that is the right time to do it. And I think these are the necessary steps to kind of build up to that. I think all I was saying was, I couldn't, in good faith, mandate that someone kind of do therapy, because in my experience, that aspect hasn't been helpful. But I think the other things that we can do to build around that and kind of having those connections creates an environment where they can also engage in some of the other programming that we offer, in order to sort of maximize the benefits that we would see. And, I think what I'm saying is actually the same position that, people like that our team, the health authority, I think also sort of all for the most part, I think um, stands stands by as well.
Thank you.
Thank you. A couple more questions in the chat here. So can you comment on growing evidence of a potential link between immunotherapy and schizophrenia?
I can't. I will say that the bulk of the research does not indicate, I mean, a link between kind of vaccination and psychiatric illnesses. Again, I think like being supportive of evidence-based medicine, I'm also quite supportive of vaccinations. But there is some data actually that suggests that there are relationships between inflammatory markers and worsening psychosis, and there have been kind of approaches to treatments that have suggested that kind of certain inflammatory processes might be out of whack in folks who are struggling with chronic illnesses, a range of different chronic illnesses. But again, that is quite far outside of my area of expertise. So really, everything that I'm reading is probably the same things that you're reading. I would not see myself as an expert in that or able to really comment on it.
Well, thank you.
Yeah.
The next question, are there studies related to late onset schizophrenic psychosis? My son was 28 when his first incident presented.
So, I mean, I think that actually 28 is, certainly within the curve that we would see. When we think about late onset psychosis, we're actually kind of thinking about it much later on. So there is a smaller blip that happens for women kind of along around the age, like around menopause. So typically kind of in the mid 50s to early 60s, there is a blip. And there are some women particularly who might have some symptoms that come up at that point. And then for men, sometimes it's kind of associated with cognitive decline, actually. But the onset at 28 is actually is again within the sort of standard curve. It's a relatively positive indicator for what it's worth. Actually, a later age of onset is kind of, just all things being equal, is oftentimes associated with a more positive outcome, especially if it's not associated with kind of a longer period of substance use prior to the onset of the symptoms itself. So because if it's happening a little bit later, people have also had a chance to like kind of develop some social relationships, had a bit of chance to kind of finish school, university, etc. Have a better sense of themselves as people as well. So hopefully, these are all sort of positive prognostic indicators.
Interesting. Yeah. And how do you address someone with, I think we kind of talked about this. How do you address someone with anosognosia to seek help? Yeah.
Yeah, I would suggest, I mean, those of you who are interested to look at Javier Amador's book and the Leap Institute page. I find those both quite helpful resources.
Yeah, for sure. And I think I saw another question. Does anyone have a question here? Otherwise, we're getting to our time. Yeah, so, and we will make this, like I said, this recording available to you. But I really do want to thank you, Dr. Menon, for coming and sharing your work and your expertise, and certainly this the interesting clinical trials that you're involved with right now. So thank you so much for taking your time on this summer evening to be with us, and thank each one of you for coming out today.